It could either be an occlusion of a vessel or a rupture of a vessel. And we said the neurologic symptoms typically last for more than 24 hours and it's of vascular origin. So basically, that's what we said stroke is. We differentiated stroke from TIA in the sense that TIA usually will last for less than 24 hours. Stroke lasts for more than 24 hours. But most TIAs tend to resolve within 30 minutes. We also talked about the evidence of infarction on the CT scan for stroke. There's no evidence of infarction for TIA. Then we moved on to talk about the various types of stroke. So we said we have two main types, ischemic hemorrhagic. Under ischemic, we can have embolic and thrombotic. And subdividing thrombotic, depending on which vessels are affected, can either affect the small vessels or the large vessels. While for embolic, we mentioned that the clot is from a distant vessel. It could either be from the heart, meaning a cardioembolic stroke. If it's not from the heart, a non-cardioembolic stroke. And the last subtype is what we call the ESOS. So embolic stroke of undetermined origin. So it's an embolic stroke, all right, but we don't know where it's coming from. So that's ESOS. Then for hemorrhagic stroke, we said there are two main types, intracerebral hemorrhage and subarachnoid hemorrhage. But some books may add subdural hematoma, just that it's more traumatic. Then we moved on to talk about the various vessels that supply blood to the brain. We said we have three main vessels. So the anterior cerebral artery, the middle cerebral artery, and the posterior cerebral artery. The anterior and middle cerebral artery originates from the internal carotid artery, whereas the posterior originates from the basilar and the vertebral artery. And we said if there's any occlusion within the anterior cerebral artery or middle cerebral artery, then it causes what we call the anterior circulation stroke, because these supply blood to the anterior portion of the brain. Whereas if it's affecting the PCA, the posterior cerebral artery, then we say the person has posterior circulation stroke. So these were the major vessels that we talked about. Then we moved on to talk about the clinical presentation. We said the neurologic deficits, it may present with aphasia, dysphasia, hemiparesis, hemiplegia, blurred vision, severe headache. Depends on the type. Some types may present with different signs and symptoms. So we said if it's affecting the frontal lobe, it may present with aphasia. So the frontal lobe is where you have the speech center, so the Broca's area. That's where it's located. So if the person has aphasia, you think about a lesion in the frontal lobe. It could also be the Wernicke's area, and the Wernicke's area is in the temporal lobe. So we differentiated expressive aphasia from receptive aphasia. And we also talked about the fact that you could also have neck stiffness, severe headache, photophobia. These are signs of meningism. So these are usually seen in subarachnoid hemorrhage. So not all hemorrhagic stroke or ischemic stroke may present with that. It's usually seen with subarachnoid hemorrhage, the neck stiffness. A severe headache is described as thunderclap. It's the worst headache in the patient's lifetime. And we also talked about the fact that some may present with hemiparesis, quadriparesis, hemiplegia, and all that. We differentiated all these types of weakness or paralysis. Then went to the diagnosis. So the diagnosis, we said the first thing is your history. After your history, your clinical examination is very important. So it can give you an idea of what is actually wrong with the person. So your GCS, your power, your tone, your reflex. It can even give you an idea of where the lesion is likely to be. So if the person is having a stroke and the patient is not able to talk, then it's likely the patient may be having the lesion in the left hemisphere. There is a right hemisphere. Most patients tend to talk unless the patient is left-handed. Then we also talked about the neuroimaging. So the clinical symptoms and the history can give you an idea the patient has stroke. But what will tell you the type is the neuroimaging, so the CT or MRI. So if you do it, it will tell you whether it's a ischemic stroke or hemorrhagic stroke. And we talked about the clinical presentation. So for ischemic stroke, present as hypodense lesion. These are dark patches on the CT scan, whereas the hemorrhagic stroke will present as white patches known as hyperdense lesions. I think we ended on diagnosis. Did we start the management?
Sure. No, please.
Okay. Any questions from our last discussions or any clarifications? All right. So if there's no question, let's start with the management. So as usual, for every management is non-pharmacological and pharmacological. So common non-pharmacological things that can be done. If a patient has stroke, you know that clinical presentation, they may have inability to swallow. They can lose their swallowing reflex. And as such, if you try feeding them, if you try giving them medication, they are unable to swallow. And there's also risk of aspiration if you try to force it down their throat. So because of that, we can pass an NG tube. So that's one of the non-pharmacological ways. So it's more of supportive care when it comes to feeding. So you pass an NG tube that can allow for feeding and also for medications. And aside that, because they may have paralysis, may be immobile in bed, there's also risk of bed sores or pressure injuries. So because of that, Hello. Hello.
Hello.
Hello.
All right. So we're talking about the supportive care. So aside the NG2 for patients who are unable to feed, there are also options to prevent bed sores because they are immobile in bed for a long time. And whenever you are immobile patients, these pressure joints, because they are on a very hard surface, they are likely to develop sores. So you want to provide an air mattress that will relieve that kind of pressure. Aside that, you can also do a 4 hourly turning in bed. So you can be turning the patient. Maybe the patient was lying on the left side. You don't want the patient lying on the left side for a very long time because the patient cannot move themselves. They are immobile. So they need some assistance. So you can do 4 hourly turning to prevent these decubitus ulcers. Aside that, patients are also unable to get up in bed to ease themselves, to urinate and all that. So you can pass a catheter to help with urine collection. Aside catheter or their fecal issues, you can also provide these pampers and all that. So these are all supportive ways and they are non-pharmacological. Because if you don't take care of all these, patient is likely to develop some infections and worsen the prognosis of the condition. They are also likely to benefit from DVT prophylaxis. So these intermittent pneumatic compressions can be provided to prevent DVT. Aside the usual TED stockings that we know, the most effective one is intermittent pneumatic compression. That one is not readily available, but if you don't get that, you can use your usual TED stockings to prevent DVT. So all these are non-pharmacological options that we look at. It cuts across for most of the conditions, either ischemic or hemorrhagic. And you may also want to elevate the head of the bed to relieve or to help reduce the intracranial pressure that may be associated, especially with hemorrhagic stroke. You want the head elevated to about 30 degrees. All right, now let's move on to pharmacological. So for the pharmacological, we start with ischemic stroke.
So, the
Yeah.
please, with the air bed, I also know of the water bed which we use.
Mm. So
Yeah.
that can also be used.
Okay.
Yeah. So for the pharmacological, for ischemic stroke, what are the options if they come in early? So someone develops ischemic stroke, they're able to detect it early. They bring the patient to the hospital. What would be your first intervention? Anyone?
You can give them some neuroleptics.
Exactly. So basically, in ischemic stroke, what is happening is you have a clot which is blocking a vessel. If this clot is blocking a vessel, it reduces. So this is an occlusion. So the clot is causing an occlusion. If the occlusion prolongs, it leads to ischemia. If the ischemia is not resolved and it prolongs, it can lead to infarction. So when someone develops ischemic stroke, they have areas that have become infected. So these infective areas, you cannot do anything about it because these areas are dead. However, surrounding the infective pore is another level of tissue, but this level of tissues have some reduced perfusion. So there's ischemia to these areas, but it's not dead yet. These areas are what we term the penumbra regions. So the penumbra surrounds the infarctive core. So it's not dead yet, but perfusion has been reduced to this area because of the occlusion. So the purpose of reperfusion therapy. Reperfusion therapy basically means restoring blood to these penumbra regions. So the purpose is to salvage these areas, because if you don't intervene early, these penumbra regions will also turn into an infarctive core. So you have an infarct. Surrounding the infarct is the penumbra. They have reduced perfusion. So our purpose is we want to establish perfusion to these areas. And to establish perfusion to these areas, we need to do either medical thrombolysis or mechanical thrombectomy. So the option for reperfusion is mechanical thrombectomy, where we go in surgically to remove the clot, or we can do pharmacological, where we give thrombolytics to break down the clot. If we do this, we are going to restore perfusion to the penumbra regions, and we are going to salvage the tissues over there. So that's the whole idea of the reperfusion therapy. We want to salvage the penumbra regions with either mechanical thrombectomy, which is surgical, or we do thrombolysis. And this is where the focus is, because a lot of facilities are not able to do mechanical thrombectomy. So we focus on thrombolysis. All right, so these thrombolytics, basically, how do they act? What's the mechanism of action? Anyone? So these agents are also known as tissue plasminogen activators. So when I was teaching you DVT, I mentioned plasminogen. I mentioned plasmin. So what happens is plasminogen is the inactive form. So it's a zymogen. So these are inactive. So fibrinogen, plasminogen is converted to plasmin. And plasmin is the active form. Basically, what plasmin does is it's going to break down the clot. So it breaks down the fibrin mesh within the clot. And that will lead to fibrin degradation products like D-dimers and all that. So basically, plasmin breaks down the clot. So the thrombolytics that we give, the altiplase, the tenecteplase, and all that, they are not the medications that are actually going to break down the clot. It does this indirectly by activating plasminogen. So once plasminogen is activated, it will be converted to plasmin. And plasmin, which is already endogenous in the system, will start breaking down the clot. So this is the basic mechanism of action. They are tissue plasminogen activators. So they activate plasminogen to plasmin, and plasmin is going to break down the clot. So there are a number of thrombolytics. So we have altiplase, we have tenecteplase, we have streptokinase, we have retiplase, we have urokinase. So all these are thrombolytics. However, it's not all the thrombolytics that are used in stroke. The thrombolytics are grouped under fibrin-specific thrombolytics and non-fibrin-specific. So we have fibrin-specific ones like altiplase, tenecteplase. These are used in stroke. But something like streptokinase, urokinase, these are not used in stroke. So the indication for thrombolytics, the FDA approved ones are altiplase and tenecteplase. The use of these medication is time bound. So remember the BFAST, the balance eye, the facial drooling or facial drooping, the arm weakness, speech impairment. Time is brain. So time is of essence. Time is brain. If you don't intervene early, the patient will lose the penumbral regions and they may turn into an infarctive region. So you have to intervene early. So the recommendation is you have to use the thrombolytics within 4.5 hours of onset of ischemic stroke. So the time here is it shouldn't go beyond 4.5 hours of onset of ischemic stroke. So if it happens 1 hour ago and they are able to get to the hospital early, the doctors will run through the history to see whether it's actually stroke. They will recommend a CT scan to be done to confirm whether it's ischemic stroke. Then they run the patient through the eligibility criteria. So the eligibility criteria, we have inclusion criteria and we have exclusion criteria. So the inclusion criteria are basically the things that are indicated for the use of thrombolytics. Exclusive criteria, the things that are more like contraindications. So if the patient came in actively bleeding, you don't want to use thrombolytics because you are going to worsen it. The patient came in, the BPs are 200 and something, you can't use thrombolytics. You have to reduce the BP before you are able to use thrombolytics. So there's a tall list of inclusion and exclusion criteria. But the general idea is that if the patient qualifies based on the inclusion and exclusion criteria, the patient qualifies, then the patient should receive the medication within 4.5 hours. After 4.5 hours, the benefits of the medication is not really seen. The risk of toxicities, bleeding tendencies are also high after 4.5 hours. So it's not recommended after that time. So currently we are working with the 4.5-hour window period. It used to be 3 hours, but now it's 4.5 hours. All right. So if you are doing altiplase, the recommended dose is 0.9 milligram per kilogram body weight. So that's the recommended dose for altiplase. The caveat is if the patient weighs more than 100 kg, you can't do above 90 milligram. So the maximum dose is 90. So if it's 0.9 milligram per kilogram and the patient weighs 120, you know definitely when you do the calculation, it will be more than 90 milligram. So any patient weighing above 100 kg, you still have to use a maximum of 90 for the patient. So assuming the patient came in 100 kg, you did 0.9 milligram per kilogram, you are supposed to give 90 milligram. This 90 milligram, you give 10% of the 90 milligram within the first minute, then the remaining, you give it as a continuous infusion over 60 minutes. So what this means is that 10% of 90 is 9 milligram. So you give 9 milligram altiplase in 1 minute as a bolus. Then you give the remaining 81 milligram as an infusion over 60 minutes. So that's how you give altiplase. So it's a basal bolus regimen. You give a bolus and you give a continuous infusion. All right. Then For tenecteplase, tenecteplase is one of the new drugs that have come up. Basically, tenecteplase is a genetically modified altiplase. So it's genetically modified altiplase. The only difference is a 3-point mutation of altiplase. So we've changed 3 amino acid residues of the altiplase, and that gives rise to tenecteplase. Basically, tenecteplase is more fibrin specific than altiplase. So that's one advantage of tenecteplase over altiplase. It's more fibrin specific. Then, in terms of cost, it's relatively cheaper compared to altiplase. So a lot of patients are not able to afford the altiplase because you come in within 4.5 hours, you are supposed to produce 20K. Because altiplase, a vial is around 15K. So if you are buying 2, that's like 30K within 4.5 hours. You may be very rich, but within that 4.5 hours, you wouldn't have 30K cash available at hand. So you can get stroked because you don't have that money at hand. You may not benefit from the altiplase therapy. But tenecteplase is relatively cheaper. You need 2 vials of altiplase because a vial is 50 milligrams. So for a usual adult patient weighing around 70, you need more than a vial. So you need 2 vials. That's like 30K. Whereas tenecteplase is around 15K. So it's relatively cheaper. And you just need 1 dose of the tenecteplase. So the dose for tenecteplase is 0.25 milligram per kilogram, and the maximum is 25 milligram. So if the patient weighs more than 100 kg, here to the caveat is you don't go beyond 25 milligram. Just like altiplase, you don't go beyond 90. Tenecteplase, you don't go beyond 25 milligram. And the other advantage is it's easier to administer tenecteplase. So you give it as a bolus over 5 seconds. So if you do patient weighs 100 kg, you do your calculation, you get like 25 milligram. That 25 milligram, you give it as a bolus very fast over 5 seconds. Unlike altiplase that you have to give it bolus over 1 minute, then remaining over 60 minutes. So you need like an hour to give altiplase. So the door to needle time of altiplase is longer compared to tenecteplase. It's faster to give tenecteplase. So the ease of administration, relatively cheaper, more fibrin specific. Then in terms of the half-life, it has a longer half-life compared to altiplase. So it has a longer half-life compared to altiplase. Then aside that, there's this enzyme known as plasminogen activator inhibitor. So plasminogen activator inhibitor is an enzyme in the body that breaks down these thrombolytics. So tenecteplase is more resistant to the breakdown by plasminogen activator inhibitor compared to altiplase. So it's more resistant, and that's the more reason why it has a longer half-life compared to altiplase. Altiplase is easily broken down, so it doesn't have a long half-life. But tenecteplase has a longer half-life. So you mentioned like 5 advantages of tenecteplase over altiplase. So in confirmation now, tenecteplase is what we use. So we recently drew the thrombolytic protocol in CAP, and what we are using now is tenecteplase, giving very good, promising results and all that. So that's the new drug that has been used. I think US hasn't approved it for thrombolysis yet, but the other countries are using it, and Ghana is also using it. Any questions?
Please, can you go over um, how the tenacity is administered?
Yeah, so that one is giving us a bolus over 5 seconds. So just 5 seconds, you push everything.
All right, thank you.
Okay. Any other question? Okay. So this is the option for thrombolysis. So why don't we use streptokinase? Because it's also one of the thrombolytics that's available on the market. So why are we not using that? Any ideas?
Risk of allergic reaction.
Okay. So why is there risk of allergic reaction?
If the person has already had a strep infection before, their body has antibodies against it. So give streptokinase, which is a like strep, it might the body will react to it like it is a foreign body.
All right. So the drug itself is obtained from the beta hemolytic bacteria. So the beta hemolytic streptococci. This is where streptokinase is obtained from. So as usual, if a bacteria or bacterial component is introduced into the system, the body detects it as foreign and tries to produce antibodies against it to neutralize it. So it's the same principle. If you give streptokinase, the body tries to produce antibodies. So the rule of thumb is you can give streptokinase for other conditions, not stroke. So you can use it in MI, you can use it in P and all that. Because for stroke, they realized there was increased mortality when they used streptokinase for thrombolysis. So the risk of bleeding was high, and the mortality among stroke patients was also high. The other thing is there's risk of allergic reaction when you use it for more than 4 days. So if you are using streptokinase for any indication, if you give it, you can repeat it the next day, the following day, but it shouldn't go beyond 4 days. After 4 days, the body produces anti-streptococcal antibodies. And these are basically supposed to neutralize the effect of the drug, and any further administration will cause allergic reactions. So usually after 4 days, you don't give it. These antibodies can stay in the body for up to even 6 months, in some patients up to 1 year. So if you give it, repeat it, no more than 4 days, then you'd have to wait for like 6 months or even a year after if you want to give it for any other indication again in that same patient. So that's how bad it is. So we usually don't use it with the new ones available. Urokinase is also not readily available. That one is obtained from
Please, can you kindly repeat the first reason before the hypersensitivity?
the risk of mortality and bleeding tendencies is high.
Thank you.
Okay. So the other ones are also not used in stroke. Urokinase is obtained from the urine of postmenopausal women and is also one of the thrombolytics, but it's not used in stroke. All right. Any questions on the thrombolytics before we move on? Okay. So the other options, if the patient is not thrombolized, then you can give aspirin. So we have antiplatelets as part of the treatment for ischemic stroke. Just that if the patient received altiplase or tenecteplase, you can't give aspirin within the first 24 hours. Some references 24 to 48 hours. This is because of the risk of bleeding. And so the risk of bleeding is very high if you are to give aspirin within the first 24 to 48 hours. So you have to hold on aspirin or any antiplatelet or any anticoagulant within the first 24 to 48 hours of giving altiplase. However, if the patient came in, the patient was maybe 6 hours, they've passed the window period, that you can start your aspirin safely because the patient didn't receive any altiplase or tenecteplase. You can start your aspirin straight away. The purpose of giving aspirin, aspirin is an antiplatelet. And you know how it acts. Basically, aspirin inhibits COX. You know the COX pathway. It starts with membrane phospholipase, then acted on by phospholipase A2 to arachidonic acid. And arachidonic acid, you have the COX-1 acting on it to produce your thromboxane A2 and your prostaglandins. You also have COX-2 acting on it to produce your prostaglandins and prostacyclin. Then your LOX pathway also acts on it. All right, so this is basically the COX pathway. So aspirin effect is on both COX-1 and COX-2. So it's an NSAID, just like the ibuprofen, the naproxen, the diclo, they are all NSAIDs. However, we don't use the other NSAIDs in ischemic stroke. Any reasons for that? Because they are all NSAIDs. Why are we using aspirin and we are not using diclo, ibuprofen, and all that? Anyone to tell us? So basically, we have NSAIDs that are selective COX-2 inhibitors, and we have the non-selective ones. So aspirin is a non-selective NSAID. So it blocks both COX-1 and COX-2. However, its antiplatelet effect is mediated by the COX-1 pathway because COX-1 produces thromboxane A2, and thromboxane A2 causes platelet aggregation and also vasoconstriction. So that's the effect of thromboxane A2. So basically, when aspirin inhibits COX-1, it means you are not going to produce thromboxane A2, for which reason you wouldn't have platelet aggregation. So that's how aspirin acts to prevent platelet aggregation. And this inhibition is done by the other NSAIDs. Just that aspirin is able to inhibit COX irreversibly. So diclofenac, they do a reversible inhibition. So you don't have a sustained antiplatelet effect. You may bleed from diclo, you may bleed from ibuprofen. It shows that they have antiplatelet effect, but it's not a sustained antiplatelet effect because it's a reversible reaction. However, aspirin is able to block COX-1 irreversibly. So that's why you use aspirin as our antiplatelet of choice in ischemic stroke. So the summary is that aspirin blocks COX-1 irreversibly to prevent thrombosin A2 mediated platelet aggregation. And that's what is going to help reduce more clot formation in the vessels. So aspirin is one of the mainstay. The dose we usually start with. What's the dose? Who can tell me the dose? Aspirin dose in the chemistry. 300 milligram. Start, right?
No, sir, for 14 days.
Okay, and that's it. So 300 milligram for 14 days, and you're done with the treatment, right?
Then you switch to 75 milligrams daily.
Okay, all right.
Dr. Shak, please, is it the same for coronary artery disease? The
No, it's
duration?
not the same. It's not the same. It's not the same. So for ischemic stroke, if you are starting aspirin, you do 300 starts. You do 300 daily for 14 days. Then you reduce to 75 milligram daily. So it's not 300 starts. It's 300 daily for 14 days. Then you reduce to 75. But if you are doing MI, then you do your 300 starts, then reduce to 75 daily. So that one is a 300 milligram start dose, reduced to 75. But in ischemic stroke, it's 300 daily for 14 days, then you reduce to 75. There's another option. All right. So there's another treatment regimen where you do 160 milligram daily for 4 weeks, then reduce to 75. So you either do 300 daily for 2 weeks, reduce to 75, or 160 milligram daily for 4 weeks and reduce to 75. And all these are backed by a trial. So when you look at the BNF talks about 300 milligram daily for 14 days. And this is because of the international stroke trial. So the international stroke trial, they used 300 milligram daily for 14 days, reduced to 75. However, the 160 milligram daily for 4 weeks, that one is from the CAST, so the Chinese acute stroke trial. So the Chinese acute stroke trial used 160 milligram daily for 4 weeks, reduced to 75. However, in Confanoche, what you are seeing is we're doing 150 daily for 4 weeks. This is because the 160 milligram is not readily available. The available strength of aspirin is 75, then 100 milligram on the market. So we rather do 2 of the 75, making 150 instead of the 160 that was actually used in the Chinese acute stroke trial. So these are the evidence that support the dosing regimen. Now, what's the rationale for the 300 milligram dose?
Hello, sir. Can you repeat the 160 dosing?
160 daily for 4 weeks, then reduce to 75.
All right, thank you.
Okay. So what's the rationale for the 300 milligram dose? Why that high dose? Any reasons?
Said the 300 milligram is to acetylate the already formed platelets.
Exactly so. So the purpose of that high dose, the 300 milligram dose, is to acetylate already aggregated platelets. You know the thrombosin A2 cause platelet aggregation. So the already aggregated platelets, you want to give aspirin, and you know aspirin is acetyl salicylic acid. So it donates an acetyl group, and that acetylates the already aggregated platelet. Once it's acetylated, it renders the platelet inactive, and they are not able to cause any further platelet aggregation. So that's the rationale for the 300 milligram dose. So what's the rationale for giving it daily for 14 days? Any reasons for that?
So I think their lifespan is about 7 to 10 days. That is why.
Yeah, so the purpose is you want to render the platelets inactive throughout the lifespan. And the lifespan of platelets is 7 to 10 days. So you usually give it for 14 days so that you are sure that you've acetylated all the platelets throughout their lifespan. What's the rationale for reducing it to the 75 milligram? Why the 75?
To prevent new platelets from aggregating.
Yeah, so that's true. So the 300 milligram, we are acetylating the already aggregated platelets. We are doing it for 14 days to render the platelets inactive throughout their lifespan and reduce it to 75 milligram to prevent new platelets from aggregating. So that's the rationale for all these things that we do. Is it clear? Okay. So, you know, aspirin cannot be given to all patients, right? So if the patient has contraindications to aspirin, for example, the patient has active bleeding peptic ulcer or aspirin hypersensitivity, like in the case of aspirin induced asthma. So, you know, some category of asthmatic patients are sensitive to aspirin based on the Samtest triad. So these category of people, they are allergic to aspirin. So you don't want to give aspirin in such patients. So in such patients, the alternative would be to give clopidogrel. So how does clopidogrel act? Anyone to tell us? All right, so clopidogrel is also an antiplatelet. Just that for platelet aggregation, it's not just the thrombosin A2 that causes platelet aggregation. There are other inducers of platelet aggregation, and one of them is the adenosine pathway. So what clopidogrel does is it inhibits the P2Y12 receptor on platelets. So basically what clopidogrel does is it inhibits the P2Y12 receptor on platelets, and that prevents adenosine-mediated platelet aggregation. So that's a simple mechanism. Inhibits the P2Y12 receptor on platelets, thereby preventing adenosine-mediated platelet aggregation or AP-mediated platelet aggregation. It's the same thing. So for patients with contraindications to aspirin, you can fall on clopidogrel. And basically, in terms of efficacy, there is no clear evidence to show that clopidogrel is superior over aspirin or aspirin is superior. Just that for patients with contraindications to aspirin, that's when you fall on clopidogrel. So the dose for clopidogrel is 75 milligram daily. So that one, you don't have to do 300 stats and all that. It's just 75 milligram daily. Unlike when you are doing in MI. MI, when you are doing that, you do your aspirin 300 stats, 75 daily, clopidogrel 300 stats, 75 daily in the dual antiplatelet therapy. But clopidogrel in stroke, you just start with 75 milligram daily. The issues with clopidogrel. So, for example, patient has active bleeding PUD or peptic ulcer, for which reason you can't give aspirin. So you decided to do clopidogrel. The patient has PUD, so it's likely the patient will be on, say, omeprazole for the treatment. And you also want to give clopidogrel. What's the issue here? Anyone? Patient is on omeprazole, can't take aspirin because of the PUD, and you are giving clopidogrel. What is the issue here?
Except if both drug needs the cytochrome enzyme to be activated. So if you are giving the two together, one may be activated while the other will be in inactivity.
Okay. But there are some things that you've not said. So which one is inactive? Which one will be active? So you have to go further. Anyone to help us? Did I start mentioning names?
Hello, Doc.
Yeah.
Yeah, please. With respect to giving clopidogrel and omeprazole together, clopidogrel is a prodrug, and it requires activation by the cytochrome 2C19 enzyme. However, omeprazole also inhibits this same enzyme. So giving them together, there is going to be an inhibition of the conversion of clopidogrel to its active form. Hence, clopidogrel will fail to act.
Exactly so. So what you should understand is clopidogrel that you are giving is a prodrug. It's not the active drug. So it needs to be activated into the active form. And the activation is done by cytochrome 2C19. This cytochrome 2C19 is also inhibited by omeprazole. So omeprazole inhibits cytochrome 2C19. So if you do a concomitant administration of clopidogrel and omeprazole, what will happen is omeprazole would inhibit cytochrome 2C19, preventing the conversion of clopidogrel into its active metabolite. And what you should understand is the antiplatelet effect of clopidogrel is derived from the active metabolite. So if there's no conversion to the active metabolite, that antiplatelet effect wouldn't be realized. So all that we are saying is if you do the concomitant administration, you wouldn't have the conversion to the active metabolite, and the clopidogrel, you wouldn't get the benefit, the antiplatelet benefit, since the active metabolite wouldn't be formed. So for such patients, you would have to do an alternative. You know, the alternative, you can't go back to your aspirin because the patient has PUD. So you should work on alternatives for the omeprazole. So the alternative for the omeprazole, you can do your H2 receptor blockers. However, the H2 receptor blockers, cimetidine is a no-go area because it's also one of the potent enzyme inhibitors. So you don't want to go in for cimetidine. Ranitidine can also be used, just that the recent issue about ranitidine is that they realize some products, Zantac, which is the originator brand, contained some potential carcinogenic substances. And for which reason, they recalled all Zantac and ranitidine containing products. So it's very hard to get ranitidine on the system now, and because of the potential carcinogenic effect. So that's also out. So the options you can do is famotidine. As that famotidine is also not readily available, even though it's available, but it's not readily available. And the other issue is the A2 receptor blockers are not as effective as PPIs. They will only block one pathway of the acid production, which is the histaminergic pathway. The gastrin pathway is still there. The acetylcholine pathway is still there. So you need to block the proton pump itself. So the option for omeprazole is you can't do esomeprazole. So esomeprazole and omeprazole are no-go area because these are strong cytochrome 2C19 inhibitors. So the other options is to do lansoprazole, rabiprazole, or pantoprazole. Even though these also inhibit the enzyme cytochrome 2C19, but they are weak cytochrome 2C19 inhibitors. So you can fall on lansoprazole, rabiprazole, or pantoprazole. These are the options that can be used. Is it clear? All right, so let's move on to talk about statin therapy. So we are still on ischemic stroke. So for patients who are able to benefit from Altiplase, after 24 to 48 hours, you can start with your aspirin. You can also start your statins. So basically, you know how statins act. They reduce cholesterol production by inhibiting the rate-limiting step, which is catalyzed by the HMG-CoA reductase enzyme. So that's how the statins act. So for every patient who comes in with ischemic stroke, one of the last that you want to do is the lipid profile, because the clot that is formed is not just platelets, but lipids are also involved. So you know the mechanism of plaque formation when you were learning MI. So endothelial injury, you have collagen being exposed, fatty streaks, you have platelet aggregation, foam cells and all that. So it's the same mechanism. So fat is also involved. So you want to reduce the lipids in the body. However, irrespective of the baseline lipid profile, whether it's high, normal, or low, once the patient has developed ischemic stroke, the patient should be put on a statin. So what this means is that if you check the lipid profile and it's normal, patient still needs a statin. If it's low, patient will need a statin. If it's high, patient will still need a statin. So irrespective of the baseline lipid profile, If the patient has developed ischemic stroke, you have to put the patient on a statin. That tells you that we are looking beyond lipid lowering, because if the lipid profile is normal or low, why the need for a statin? So we are not just looking at lipid lowering, but we are looking at other benefits beyond lipid lowering. And these are what we call the pleiotropic effects of statins. So what are some of the pleiotropic effects of statins you know?
So for the pleiotropic effect, we have the anti-inflammatory, anti-proliferative, anti-thrombotic, antioxidants, the improving endothelial function, and also increasing nitric oxide production.
Exactly. So it has anti-thrombotic effect, antioxidant effect, anti-inflammatory, anti-proliferative effect. It helps with plaque stabilization. It improves endothelial function by increasing nitric oxide availability. All these are pleiotropic effects of the statins. So aside the lipid lowering, these are the other benefits. And antithrombotic will be helpful because here you have platelets aggregation and all that, causing clot. So antithrombotic effect will be beneficial. Antioxidant effect definitely will be beneficial here. So all these are important benefits. And after the plaque has formed, the statin can also stabilize the plaque to prevent breaks and any embolization to a distant vessel. So all these are other benefits that we see from the statin. In terms of the dosing, the recommendation is to start a high-intensity statin. When we say a high-intensity statin, it doesn't mean high-dose statin. High-intensity statin means the dose of the statin that is able to reduce LDL cholesterol by 40%. And this is based on the British references, where the BNF will quote the dose of the statin that's able to reduce LDL cholesterol by 40%. However, the American guidelines, American Stroke Association and all that, they talk about the dose of the statin that reduces LDL cholesterol by 50%. So that's the disparity. The British talk about 40%, the American talk about 50% reduction in the LDL cholesterol. So our usual statins that we have available, atorvastatin, rosuvastatin, these are the very common ones. All the statins, you have to know, are metabolized by the liver. It's the excretion that differs. So they are all metabolized by the liver. It's the excretion that differs. So atorvastatin is excreted by the liver. Atorvastatin is a lipid-soluble statin. We have lipid-soluble statins and we have water-soluble statins. Atorvastatin is one of the lipid-soluble statins. Simvastatin, lipid-soluble. Rosuvastatin was water-soluble. So the lipid-soluble statins, usually their excretion is via the hepatic route. The water-soluble is usually via the renal route. So for atorvastatin, metabolized by the liver, excretion via the liver, whereas the rosuvastatin, more renal. So atorvastatin will be preferred in renally impaired patients because it's excreted by the liver, so it's preferred in renally impaired patients. But rosuvastatin will be preferred in liver impaired patient because that one is excreted renally. So these are some of the dynamics that would help you choose either atorvastatin or rosuvastatin. So for the high intensity dose of atorvastatin, we are looking at doses around 40 to 80. So if you are going by the British references, then 20 milligram atorvastatin even qualifies to be high intensity because it reduces LDL cholesterol by 43%. And per our definition, the dose of the statin that reduces the LDL by 40%. So if 20 milligram is reducing it by 43%, and we can say it's also high intensity. But the American references start from 40 to 80 because they are looking at a cutoff of 50%. So they choose 40 to 80. But all these are high intensity doses. But the dose that is actually recommended in stroke secondary prophylaxis. So all that I've been talking about are for secondary prophylaxis, the aspirin, the clopidogrel, the statins, secondary prophylaxis. And when we say secondary prophylaxis, the patient has already developed stroke, and you are giving these agents to prevent a new stroke from occurring and other secondary cardiovascular events like MI from occurring. So we are preventing new stroke and other cardiovascular events. So we call it secondary prophylaxis. But if the person had not developed stroke and we put the patient on the statin and all that, that's primary prophylaxis. So here, I've quoted doses of 20, 40, 80 and all that to be high intensity. However, the dose that is actually recommended is atorvastatin 80 milligram. And this is from the Sparkle trial. So the Sparkle trial, they use 80 milligram atorvastatin as secondary prophylaxis for ischemic stroke patients. And they realized the benefit was immense. So if you check your BNF for the dose of atorvastatin, BNF wouldn't quote 40 to 80 or 20 to 80 or something. It will just quote 80 milligram because that's the evidence from the Sparkle trial. That's what they used. So the 80 milligram is what we use for ischemic stroke. If the patient is not tolerating that high intensity dose based on maybe side effects like muscle pain, rhabdomyolysis, liver, hepatotoxicity and all that, then you may want to reduce the dose to say 40 milligram, but the recommended dose is 80. Any questions?
Please, I have a question.
Okay.
Okay, please, if the cause of the stroke is a cardioembolic source, like does the patient still qualify for statin?
Okay. So for cardioembolic stroke, the management is different. For cardioembolic stroke, you have to establish the cardioembolic cause. There are a lot of cardioembolic causes, but the common one is atrial fibrillation. If the patient has atrial fibrillation, you have to calculate what we call the CHASVA score. And the CHASVA score will tell you whether the patient is at risk of stroke or not. That is for a patient who hasn't developed stroke yet, has atrial fibrillation, or if the patient has developed stroke and you find out they also have atrial fibrillation. That one straight away, you're starting with your anticoagulant. Aside your strategies for atrial fibrillation, which is the rate control and the rhythm control, you have to put the patient on anticoagulant. If the patient is having stroke and also having atrial fibrillation. However, if it's just atrial fibrillation without stroke, then you have to calculate the CHASVA score. If your CHASVA score is 2 or more, then that's high risk for stroke. So such patients should be on anticoagulation. Usually, We do anticoagulation in these patients because of the nature of clot. If you remember from our DVT and P discussion, we mentioned what a red thrombosis and what a white thrombosis. So here, there's clot formation in both cases. Red thrombus, there's clot. White thrombus, there's also clot. But the nature of the clot. So if a clot is formed within the arteries are fast-flowing vessels where blood moves very fast. So if there's an injury to the endothelial lining, you have platelet aggregation. And because you have a lot of platelet aggregation, the nature of the clot that is formed is platelet-rich. And that's what we call the white thrombus. Whereas for veins, the blood moves very slowly. And you remember from the virtuous triad that we have venous stasis, we have hypercoagulability, and we have endothelial injury. So whenever blood is moving very slowly, there's tendencies of stagnation. So when blood is stagnant, you have clotting factors aggregating, starting the clotting cascade and all that. So the nature of the clot formed in the veins is clotting factor rich or fibrin rich. So because of that, it's termed as a red thrombus, and you have to use anticoagulants. So for atrial fibrillation, we use anticoagulants. However, if it's a stroke forming within the arteries, then we use the antiplatelets. If the cause is cardioembolic, you use anticoagulant. Usually, if the clot is very big, there's a term we call hemorrhagic transformation. What hemorrhagic transformation means is that you have an infarct, and because you started your anticoagulant or you started your thrombolytics, it changes this infarctive core into a bleed. So the place where you had the infarct now transform into a bleed. So that's what we term hemorrhagic transformation. And this is because of the use of anticoagulants, thrombolytics, if you are using it when the clot is very big. So the rule of thumb is for cardioembolic stroke, you don't start anticoagulation immediately because of the risk of hemorrhagic transformation. So you can put the patient on your aspirin for about 10 to 14 days. After 10 to 14 days of being on the aspirin, you can switch to your rivaroxaban, your Clexane, your apixaban. These are anticoagulants. But the patient has to be on aspirin for 10 to 14 days before you switch because of the risk of hemorrhagic transformation. And because the nature of the clot is not rich in a lot of fat, statins are not used as part of the cardioembolic management unless the patient has a baseline lipid profile, which is shown dyslipidemia, LDL is high, HDL is low, and triglycerides are high. Then it's a clear indication to put the patient on a statin. However, if the lipid profile is normal, there's no need for statins if it's cardioembolic. Statins are used when it's affecting the large arteries or the small vessels. So these usually white thrombus, you have a lot of fat, you have a lot of platelets. So this is where you use your statins. Is it clear?
Yes, please. Thank you.
Okay. Any other question?
And Dr. Aisha, please, sorry for taking you back. With the fibrinolytic and the aspirin, how long will you switch after the fibrinolytics? Will you start the aspirin?
So you wait for at least 24 hours. Within the first 24 hours, you don't start. You can start after 24 hours. Some reference talk about 24 to 48 hours. So it's more prefer to start after 48 hours because of the risk of bleeding.
Okay, thank you.
Any other question? All right. So these are the options for management. So your alteplase, your aspirin, your statins. Okay. Aside that, there are options for some potential neuroprotective agents. Currently, there is no approved neuroprotective agent. One that has shown promising results is hypothermia. That is the more reason why most of the stroke units, you have air conditioners there to help keep the place very cool, because hypothermia has been shown to be neuroprotective, showing some promising results to be neuroprotective. But there's no approved product for neuroprotection. There are options that are used, and there are some trials to back some of them. So one of them is somazina. And basically, somazina, the active ingredient is citicoline. So it's available on the market. Then we also have piracetam. Piracetam, common brand name is Sebrotonin and Neutropil. So piracetam, common brand name Sebrotonin and Neutropil. So this is also available on the market. Then there's also Neuroxan, Neuromind, Intellector. All these are agents that are purported to be neuroprotective. But currently, there's no approved neuroprotective agent. All the things that we are doing are more of managing the symptoms, supportive care. So we don't have anything for neuroprotection. Citicoline is very much used in the hospitals. And basically, when you have ischemic stroke, it damages the neurons. And the neurons, the neurons have cell membrane. The cell membrane is made up of membrane phospholipids. And the common membrane phospholipids, phosphatidylcholine and phosphatidylserine. These are the common phospholipids that make up the cell membrane, phosphatidylcholine and phosphatidylserine. So basically, citicoline is a choline analog. So it's a synthetic choline analog. And this choline analog is what is going to serve as a precursor for the synthesis of phosphatidylcholine. So it serves as a precursor for the synthesis of phosphatidylcholine. So essentially what we are doing is we are increasing the substrate that is needed to make up these membrane phospholipids like phosphatidylcholine. And once there's damage to the neuron, the body tries to regenerate new ones. The new ones will need cell membrane. So you need precursors to make up these phosphatidylcholine. So that's the purpose of giving citicoline. Aside that, it also has antioxidant properties, and it also helps reduce cerebral edema by maintaining the integrity of the cell membrane. So these are some of the benefits of starting citicoline. The evidence from the ICTUS trial, so there's a trial known as the ICTUS trial, where they use citicoline. Citicoline started within the first 24 hours of onset of ischemic stroke, continued for about 3 months, has been shown to improve the general stroke outcomes and also improved the symptoms. So that's the purpose of giving the citicoline. We want to improve the outcome and also cognitive effects and all that. And the evidence from the ICTUS trial is if you start early within the first 24 hours, then you continue for 3 months. There is not just giving it for 1 week or 2 weeks. You didn't see any benefit. You have to give it continuously for 3 months. That's when you see the general benefit of citicoline. And the dosing is 1 gram daily. It comes in the form of sachets. Now there are tablets available, and there's also injection available. So you give 1 gram daily, and you continue for 3 months. You can do up to a maximum of 2 grams. So you do 1 gram BD. So the maximum daily is 2 grams. Any questions? So citicoline can be used for both ischemic and hemorrhagic stroke. So it's safe to use in both ischemic and hemorrhagic. The other option is paracetam. So paracetam is basically a hematorheologic agent. So we call it hematorheologic agent. You remember from your dispensing rheology. So rheology basically looks at the flow of substances. So when you are looking at powders, you are looking at how powders flow. So rheology. So basically, paracetam is a rheologic modifier. And what it means is that it's able to reduce the viscosity of blood. And by reducing the viscosity of blood, it makes blood flow easily. So it increases the rate at which blood flow. It also has antiplatelet effect. So aside the hematorheologic agent, where rheologic effect, where it reduces the viscosity of blood, it also has antiplatelet properties. And it also improves RBC deformability. So from your sickle cell lectures, when you were learning about hydroxyurea, you mentioned that hydroxyurea increases fetal hemoglobin and it also reduces the sickled hemoglobin. It also improves RBC deformability. So sickled RBCs are very rigid. They are in the form of a crescent shape. They are not able to meander or go through these small vessels. They get stuck in these small vessels to cause the vaso-occlusive crisis, However, for the normal RBCs, biconcave and is very flexible. So it can change its shape at any time if it's trying to meander through smaller vessels. And this is what we call RBC deformability. It changes the shape and allows it to move through these smaller vessels. So hydroxyurea improves its ability to do that. The same way paracetam also improves RBC deformability so that the RBCs can easily move through these smaller vessels and improve perfusion. So basically, all that paracetam is going to do, reduce viscosity of blood, prevents platelet aggregation, allow RBCs to meander through smaller vessels. So they are basically improving the flow of blood in the cerebral vessels. And because of the nature of their mechanism of action, paracetam can only be used in ischemic stroke. It's contraindicated in hemorrhagic stroke. So you don't use it in hemorrhagic. Its benefit is only in ischemic stroke. And with that one, usually the dosing is, you can do about 800 milligram to 1.6 milligram TDS. So it comes in the form of 800 milligram dose strength. So you can do 800 to 1.6 milligram TDS. Okay. Any questions? All right. There's option for. So there was a time where fluoxetine was being used. You know, fluoxetine is an SSRI, so selective serotonin reuptake inhibitor, and basically, its main indication is depression. One of the common complications of stroke is post-stroke depression. So after stroke, maybe you're able to go about your everyday activities, you're able to walk, you're able to do everything that you want to do. But you develop stroke and now you are bedridden, you are not able to do the things that you are supposed to do. You can't bath on your own, you can't do anything on your own. Someone has to assist you. So you may develop depression. So fluoxetine is beneficial in post-stroke depression. Aside that, there were some trials that were looking at the use of fluoxetine to improve motor recovery. So there was a trial which is known as the FOCUS trial. So the FOCUS trial, basically, they put patients on fluoxetine for about 3 months. They recruited ischemic stroke patients, about 118 of them, and they put them on fluoxetine for 3 months. And the deduction was that, so they actually combined fluoxetine with physiotherapy and all that. So after 3 months, the conclusion was that fluoxetine, when combined with physiotherapy, improves motor recovery. And it also reduces post-stroke depression, which we already know. Mhm. But the issue with this study was fluoxetine or physiotherapy alone is enough to improve motor recovery. So they're combining fluoxetine with physiotherapy. Hello. Hello.
Hello.
Yeah, sorry, I went off a little bit. So I was talking about the use of fluoxetine. So basically, the flame trial recruited ischemic stroke patients, and they studied them for 3 months. When combined with physiotherapy, they concluded that it improved motor recovery. So there were issues with that because physiotherapy alone can improve motor recovery. So we can't tell whether the benefit was actually from the fluoxetine or the physiotherapy. So there were other trials that came up, which was the focus trial. So the focus trial came to debunk some of the claims in the flame trial. So they recruited both ischemic and hemorrhagic stroke patients, about 3,127 of them. So in terms of the sample size, way larger than the 118 in the flame trial. And basically, they studied the patient for 6 months. So instead of 3 months, they studied the patient for 6 months. And they concluded that fluoxetine, when compared with placebo, does not show any significant increase in motor recovery compared to placebo. And the only benefit was the fact that it improved post-stroke depression, which is not something unusual because it's already an antidepressant. There are new trials that have come up, the affinity and the effects trial. All these trials didn't show any benefit of fluoxetine in improving motor recovery. So now, if you are using fluoxetine, it will be for post-stroke depression. Its benefit in motor recovery is not significant, for which reason we use it. And if you are just putting the patient on it, know that there were risks that were seen from the trials. So aside the fact that it's not able to improve motor recovery as purported in the flame trial, there were risk of hyponatremia. So fluoxetine can cause SIADH, which is syndrome of inappropriate ADH secretion. And you know what ADH is? Antidiuretic hormone. So it tends to retain more water without sodium, and that can cause a dilutional state. So you can have hyponatremia as a result of SIADH from fluoxetine. There's also a risk of bone fractures from fluoxetine that were seen all in the trials. So if the person doesn't have any evidence of post-stroke depression, there's no need putting the patient on fluoxetine for motor recovery. You can just do your physiotherapy, which is one of the non-pharmacological management of stroke. Is it clear?
Yes, sir.
Okay. So basically, these are how you manage stroke patients. So if you are putting the patient on fluoxetine, it's 20 milligram daily. The preferred time to give fluoxetine is in the morning because fluoxetine can cause insomnia. If you give it at night, patient wouldn't be able to sleep. So preferred is to give 20 milligram main. Then for patients who are below 24 years, you also want to avoid fluoxetine in them because of the risk of suicidal ideation. So if the patient is below 24 years, don't give fluoxetine. One very important thing about ischemic stroke management is the BP management. So if they come in within the first 24 hours, if the BP is below 220/120, you don't have to do anything about it. Within the first 24 hours of ischemic stroke, if the BP is below 220/120, so if the kin BP is 170/90 or 180/60 something or something, you don't have to do anything about the BP. However, if the BP is more than 220/120, then you want to reduce it with your intravenous medications, your IV labetalol. This is an hypertensive emergency. You have 220/120, and there's evidence of an organ damage, which is the stroke. So you do IV instead of oral. So your IV labetalol, your hydralazine or nitroprusside. So you can do these agents. However, you don't reduce the BP drastically. So the caution here is the BP is high because the patient is not having enough perfusion to the brain. The clot is blocking the perfusion. So in order to increase the cerebral perfusion, the body tries to increase its mean arterial pressure. So by increasing the blood pressure, it increases the cerebral perfusion in the brain so that you prevent the infarct from spreading, or you prevent the ischemia region from being infarcted. So basically, when you are trying to reduce the BP, you don't reduce it drastically. That's why when it's below 220/120, you don't do anything about it. But the moment it's above 220/120, you have to reduce, but it shouldn't be more than 15% of the mean arterial pressure. So if you calculate the mean arterial pressure of 220/120, that reduction that you are trying to do shouldn't be more than 15% within the first 24 hours. So that's the rule when it comes to ischemic stroke. And this is based on the American references. But when you look at some of the Ghanaian references, I think STG, they talk about a cutoff of 180/110. So if the BP is greater than 180/110, then you give the IV labetalol. But if it's less than that, you don't give any IV labetalol. And that one, you don't reduce it by more than 20%. So the American references talk about 220/120, not more than 15%. The Ghanaian references 180/110, not more than 20%. Is that clear? Okay. So that's how you manage ischemic stroke. Let's go to hemorrhagic stroke. So for hemorrhagic stroke, basically the management differs depending on the type. So if it's subarachnoid hemorrhage, you know that the most common cause of subarachnoid hemorrhage is the rupture of aneurysms. So if the hospital is well endowed with these surgical interventions, then they can do either coiling or clipping. So these are surgical interventions for subarachnoid.
Sir, please, can you say the surgical intervention again? Sorry.
So coiling and clipping. So these are the surgical interventions for subarachnoid hemorrhage. You either coil or you clip. The patient may also be put on nimodipine. So nimodipine is a calcium channel blocker, a dihydropyridine calcium channel blocker, just like amlodipine, nifedipine, felodipine, nicardipine. All these are dihydropyridine calcium channel blockers. So basically, We are using nimodipine because nimodipine is more selective for cerebral vessels. You know, the dihydropyridine calcium channel blockers, they differ in terms of selectivity. So for nimodipine, they are saying it's more selective for cerebral vessels. When it comes to amlodipine, it's 100% peripheral, has no effect on the heart. Nifedipine is 1% on the heart, 99% peripheral. Felodipine is just like amlodipine, 100% peripheral. So they differ in terms of selectivity. So we are choosing nimodipine because nimodipine is more selective for cerebral vessels, even though it has little peripheral effect, but it's more selective for cerebral vessels. The other reason why we choose nimodipine is because it's highly lipophilic compared to the other ones. And what this means is that it can easily cross the BBB and get into the brain. It's highly lipophilic, can easily cross the BBB and get into the brain. And here the focus is the drug getting into the brain. So we need something that's highly lipophilic and also cerebral selective. The purpose of nimodipine is to prevent delayed cerebral ischemia as a result of cerebral vasospasms. So if you have a subarachnoid hemorrhage, as one of the complications, you can have cerebral spasms. So spasms of the cerebral vessels. And spasms will cause a reduction in the lumen, and that can cause ischemia. So you have hemorrhagic stroke, all right. But this hemorrhagic stroke, if you don't manage this, it can lead to ischemic stroke. So delayed cerebral ischemia, if it occurs, it can lead to an infarct. So you have to be careful. So to prevent that, we put the patient on nimodipine. So nimodipine, calcium channel blocker, so it prevents calcium influx into the vessels for 4 days of onset of subarachnoid hemorrhage, so 96 hours. So that's the preferred time to start nimodipine. So you can start it within 24 hours, within 48 hours, but it shouldn't go beyond 4 days. So the benefit is within the first 96 hours or 4 days. And you do a dose of 60 milligram 4 hourly for 21 days. So that's the dosing regimen. A lot of doctors tend to make this mistake of prescribing it QID. QID doesn't mean 4 hourly. QID is every 6 hours. So 4 hourly is 6 times a day. So you do 60 milligram 4 hourly for 21 days. The purpose of starting within the first 4 days of onset of subarachnoid hemorrhage, we are saying that we want to prevent vasospasms. So you should know when the vasospasms start. So the vasospasms usually start after 4 days, peaks within 5 to 9 days, and last for 21 days. So it starts after 4 days, peaks within 5 to 9 days, then it lasts for a duration of 21 days. So the purpose of starting within the first 4 days is to prevent the vasospasms from starting. So if you don't start it within the first 4 days and you come and start on the 5th or 6th day, by that time the vasospasms would have already started. So what you are doing is not prevention because the thing has already started. So what to prevent it from happening, that's why we are starting within the 4 days or 96 hours. And we do 60 milligram 4 hourly. 4 hourly because the drug has a very short half-life. So the half-life is 1 to 2 hours. So you have to give it multiple times in a day, about 6 times. because of the short half-life of 1 to 2 hours. And you do it for 21 days because of the duration of the vasospasms. It's 21 days. Because it's unusual to take medication for 21 days. What we know is usually 30 days. So why 21 days? So 21 days because the vasospasms last for 21 days. After 21 days, you are sure there is no vasospasms going to occur. So there's no need taking any extra doses of the medication. Is that clear?
Yes, sir.
Hello, Doc.
Hello.
Yeah, Doc, good morning, please.
Yeah, good morning.
Yeah, please, I want to find out, maybe this patient we are talking about, is he on admission?
Yeah, so I'm not talking about any particular patient.
Okay, yes, please. That's how I want to preface my question. So,
So,
based on that, some patients are not so much adherence to medication. So, since this is a drug which has to stay like with the patient for 21 days, this patient is not adherent and he goes contrary to what you advise. Will you want to end at the 21 days or you won't proceed?
So the drug is actually given for 21 days. So if the patient is not compliant, there is no need even continuing because the duration is actually 21 days. So for even compliant patients who are willing to take the medication, it's for 21 days. There's no need going beyond the 21 days. That's why you have to make sure that for the one who is not compliant, they are able to wake up or remember to take their medication every 4 hours. So they can set an alarm every 4 hours. It will give them an alert to take their medication.
Okay. Okay, Doc. Thank you very much, Doc.
Okay. All right. So,
Lord Dr. Zara.
yeah.
Yeah. Just to pick up from what Solo just asked, I would like to find out, assuming the patient has difficulty in swallowing, is the nimodipine be able to reconstitute it or something like that? Or if there is any option to give?
Yeah. So the patient cannot swallow. You can break or you can, what do you call it? You can crash the nimodipine tablet. It's not a sustained release preparation. What we have available is not sustained release. So you can actually crash it, mix it with some water and give it via NG2. There's IV formulations of nimodipine, but the IV formulation is not to be given for prophylaxis of the cerebral vasospasm. If someone has developed the vasospasms already and you are treating, then you give IV nimodipine. So for nimodipine, you only give the tablet for the prophylaxis to prevent it. If it happens, then you give the IV formulation.
Okay, thank you.
Dr. Ishak,
Yeah.
please with the status, can that one to be crash for patient who cannot swallow?
Yeah, you can crash it. So far as the medication is not sustained release, you can crash.
Okay, thank you.
Okay. So aside
So,
okay.
please, sir, IV nimodipine, what dose do you give for the treatment?
So that one, it depends on the patient's weight. So some patients will receive 0.5 milligram, others will receive 1 milligram. So it depends on the patient's weight. So you give it per hour. So if the patient is below 70, it's 0.5 milligram per hour. Then you can increase after 2 hours. But you have to be monitoring because the effects of the IV nimodipine, it can drop the BP. So you can increase it every 2 hours. If there's no BP drop, you can increase it every 2 hours till you get to 2 milligram per hour. And you can continue giving it for about 5 days. Some can go up to even 14 days. But if the patient is 70 kg and above, then you do 1 milligram increase if there is no drop in BP to 2 milligram per hour. The same thing for 5 days can increase to up to 14 days.
Hello,
Any
Dr.
more
Aisha. I
questions?
didn't get what you just answered. I didn't hear everything, sir.
So I was talking about the dose for IV nimodipine. So if you are treating someone who has developed the delayed cerebral ischemia from subarachnoid hemorrhage, depending on the weight, so below 70 kg, then you are doing 0.5 milligram per hour. You can increase it after 2 hours if there is no drop in BP. Because it can drop the BP, even though we are saying it's cerebral selective. It has peripheral effect, and that can drop the BP. You can increase it every 2 hours. So from 0.5, you can increase every 2 hours to 1 milligram, 1.5. Then 2 milligram is the maximum amount you can give per hour. And the duration is for 5 days, maximum for 14 days. For patients who weigh above 70 kg, you don't start with 0.5. You rather start with 1 milligram per hour and increase based on the response. If there's no drop in BP after 2 hours, to 2 milligram per hour. Also for 5 days, maximum 14 days.
Thank you.
Okay. So that's how you give nimodipine. If the patient has liver impairment, then you can reduce the dose from the 60 milligram 4 hourly to 30 milligram 4 hourly. If there's liver impairment, you have to reduce the dose. And nimodipine also interacts with grapefruit juice. So as part of the counseling point, you don't want them to take grapefruit juice at the same time as nimodipine. You know, grapefruit juice is an enzyme inhibitor, 3A4 inhibitor. Nimodipine is metabolized by the 3A4 enzyme, so you don't want them taking it with these grapefruit juice. And it also interacts with food. So because it interacts with food, the recommended counseling point is you take it 1 hour before meals or 2 hours after meals. So you should be taking 1 hour before meals or 2 hours after meals. So this is because food reduces the bioavailability and the peak concentration. So you want to take it an hour before or 2 hours after meals. All right. Aside nimodipine, for subarachnoid hemorrhage, you also want to put them on an osmotic agent. So they are bleeding into the brain, and that can increase intracranial pressure. So you can do either mannitol or hypertonic saline to reduce the intracranial pressure. And you know there are signs of ICP, increased ICP. So one of the signs of increased intracranial pressure is that the patient may present with very severe headache. It can tell you there's increased intracranial pressure, even though a lot of things can cause headache. So you may not want to use it as a standalone. The doctor can also do fundoscopy. So there's an instrument known as the fundoscope. So the doctor will use the fundoscope to view the pupils and the eyes. So basically, the fundoscopy here is to check for increase in intracranial pressure. And the evidence of increase in intracranial pressure on the eye is what we call papilledema. So papilledema is inflammation of the optic nerve. So when they do the fundoscopy, the doctor is able to tell whether there's inflammation to the optic nerve or not, or there's evidence of papilledema. If there is no evidence of papilledema, then it's likely the patient does not have increase in intracranial pressure. But if there's evidence of papilledema, then possibly the ICP is increased. Aside that, you can also use what we call the Cushing's triad. So Cushing's triad. Who can tell me what Cushing's triad is? What symptoms make up the Cushing's triad? Anyone? All right, so here you check the BP. So if you check the BP and the pulses are low, there is bradycardia. One of the signs of increased intracranial pressure is the low pulses, so bradycardia. Then you also look at the BP. If the diastolic and the systolic are very wide, so you know the normal BP is 120/80. So the difference is around 40 millimeters mercury. If you do the BP and you realize maybe systolic is around 200, diastolic is around 80. So that's like a difference of 120. So this is what we call a widened pulse pressure. So widened pulse pressure doesn't mean pulse, but we are looking at the BP, the difference in the diastolic and the systolic pressure. So if the difference is very wide, the normal pulse pressure is around 40 to 60. So if it's beyond 60, then we are looking at a widened pulse pressure. So that is also one of the signs of increase in intracranial pressure. Then they could also have abnormal respiration. So you know the normal respiration, 12 to 20 cycles per minute. So if it's above that, it's abnormal. So these are the three things that make up the Cushing's triad. So abnormal respiration, widened pulse pressure, then bradycardia. So it's also one of the signs of increase in intracranial pressure. They can also check the optic nerve sheath diameter. So this is what we call the ONSD, optic nerve sheath diameter. This is usually done at the ICU where they put a probe on the eyelids and they try to check the diameter of the optic nerve. If the diameter of the optic nerve is more than 0.5 centimeters, then we are looking at an inflamed optic nerve. So that's a sign of increase in intracranial pressure. But if it's less than that, then there's no increase in intracranial pressure. So all these are ways that can be used. The main thing is the invasive one, which we don't do, where they put a probe to check for the
Hello, sir.
intracranial
Can you
pressure.
repeat the diameter again?
Optic nerve sheath diameter. So yeah, they're talking about the diameter of the optic nerve. So they put a probe on the eyelids. And basically, it's just like the ultrasound. So the probe they use for the ultrasound is the same probe, or the probe they use for echo, the same probe. So they put on the eyelids to check for the diameter of the optic nerve. If the diameter is more than 0.5 centimeters, then it means the patient has increased intracranial pressure. But if it's less than that, then there's no increase in intracranial pressure. So that's how we check for the optic nerve sheath diameter. All right, so in the management for the increase in intracranial pressure, the options are osmotic agents like mannitol or hypertonic saline. So you know what mannitol is. It's an osmotic diuretic. Basically, what mannitol is going to do is it's going to increase the serum osmolality. So it stays within the serum and increases the osmolality of the serum compared to the brain. So the serum or the blood becomes more concentrated compared to the brain. And what happens is, based on the principle of osmosis, water will move from a region of high water concentration to a region of low water concentration. So the blood, which is more concentrated, would draw water from the brain onto itself. So that's how the edema and the increase in intracranial pressure reduces in the subarachnoid hemorrhage. The same principle for hypertonic saline too as well. The serum becomes more concentrated compared to the blood in the brain, drawing more water to the serum. For mannitol, the dose is based on the kilogram body weight. There is a dose range of 0.25 to 2 grams per kilogram body weight. So 0.25 to 2 grams per kilogram body weight. That's that most patients will be on 0.5 to 1 gram per kilogram body weight. But it's a dose range from 0.25 to maximum of 2 grams per kilogram body weight. And you can repeat about 2 or 3 times after. So assuming the patient weighs 50 kg and you are doing 1 gram per kilogram body weight, what it means is we are going to give 50 grams of mannitol, right? And when you take 1 bag of mannitol comes as 10% and 20%. So the 10% mannitol means 10 grams in 100 mils. So to get 50 grams of mannitol, you need the 500 ml bag. Because if 10 grams is in 100 ml, then in 500 ml, you have 50 grams. So if you see 10% mannitol, 500 mils, then it means that we are giving 50 grams of the mannitol. So you can do TDS for the patient. The caution here is that if you are giving mannitol, you give it over 30 to 60 minutes. Why do you give it over 30 to 60 minutes? Anyone? Any reason why you give it over 30 to 60 minutes?
So if it goes beyond, it can cause rebound effect.
Yeah, so there's risk of rebound increase in intracranial pressure beyond the 60 minutes. So because of that, you limit the administration to 30 to 60 minutes. So, you know, what happens is there's something called reflection coefficient. So reflection coefficient is basically the ability of the osmotic agent to cross the BBB. So this is given as an integer from 0 to 1. So for mannitol, the reflection coefficient of mannitol is 0.9, whereas the reflection coefficient of hypertonic saline is 1. So what it means is that if it's 0, 0 means it can easily cross the BBB. So I said it's from 0 to 1, given us an integer from 0 to 1. 0 means it can easily cross the BBB. 1 means it does not cross the BBB. So if we say monitor coefficient, reflection coefficient is 0.9, in percentage wise, it means 90% will stay in the serum, then 10% can cross the BBB, because 0.9 is 9 over 10. So 9 will stay in the serum, then 1 in terms of percentage will be 10% getting into the brain. So that's the reflection coefficient of mannitol. However, the reflection coefficient of hypertonic saline is 1. And 1 means it does not cross the BBB. So you can leave hypertonic saline on the patient for 24 hours, 48 hours, without it causing rebound increase in intracranial pressure, because it does not cross the BBB. However, mannitol 10% cross, 90% stays in the serum. That is if we are limiting the duration to 30 to 60 minutes. However, beyond the 60 minutes, we are not giving it beyond 60 minutes, because beyond 60 minutes, it shouldn't be 10% no more, because when we talk about osmosis will continue to occur until you achieve equilibrium and all that through a semi-permeable membrane. Here, your semi-permeable membrane is your BBB. So if you leave it there for a long time, the mannitol starts to move to the brain. So it will get to a point, may increase from 10 to 20, 30. Realize it will get to a point where the amount of mannitol in the brain becomes more than the serum. And that begins to draw water and fluid back to the brain. So it is more like a reverse osmosis occurring. So instead of water and fluid being drawn from the brain, now mannitol has concentrated in the brain and now drawing or pulling water back to the brain. So you can have a rebound increase in intracranial pressure by leaving the mannitol to run over or to run beyond 60 minutes. So the rule of thumb is you allow it to run over 30 to 60 minutes, not beyond 60 minutes. But hypertonic saline doesn't cause the rebound effect. So that's one advantage of hypertonic saline over mannitol. The other issue is mannitol, there's high risk of AKI from mannitol compared to hypertonic. You know, it's an osmotic diuretic, so it reduces the circulating volume, can cause dehydration, and you know dehydration can cause prerenal AKI. So there's risk of AKI from mannitol as well. So generally, hypertonic saline is a better osmotic agent, does not cause the rebound increase in intracranial pressure, and has less risk of AKI. So it's preferred over mannitol. So in case you tend to use more hypertonic saline compared to the mannitol. And for hypertonic saline, you do the 3% hypertonic saline, 300 mils TDS. So it's usually between 250 to 300 mils TDS. And these volumes, is very hard to get already prepared volumes of that. So you can use alligation or your C1V1 to prepare 3% hypertonic saline from 20% and normal saline. You know the principle of alligation. Before you can do alligation, you need a higher concentration and a lower concentration. So you are preparing 3%, you need something lower than 3%, which is 0.9. That's normal saline. Something higher than 3%, which is your 20%. That's how you prepare your hypertonic saline. Any questions?
Dr. Jack, please, with regards to hemorrhagic stroke, we've already established the fact that usually aneurysms, there is a bursting, there is bleed, resulting in a hyperdense CT scan results. But I want to find out, after you reduce the ICP, what about the blood? Is there something that is done? Or
Yeah, so for the blood, the body is able to take care of the blood. Blood is basically protein. So the body will break down the RBCs. And also so what happens is there's what we call hematoma stabilization. So when you bleed, the collection of blood outside the vessel is hematoma. So the body is able to stabilize the hematoma after 48 hours. So within the first 48 hours, the body is not able to stabilize the hematoma, but after 48 hours, based on the body's own hemostatic mechanism, it's able to stop the bleeding after 48 hours and stabilize the hematoma. However, there are benefits of tranexamic acid based on the TIC trial. So the TIC trial, tranexamic acid in intracranial hemorrhage, they use tranexamic acid within the first 24 hours. So within the first 24 hours of tranexamic acid, they realized that there were benefits of stopping the blood. So you can use that as well. But after 24 hours, there's no benefit of tranexamic acid. So if they come in early, within 24 hours, you can use your tranexamic acid. However, if the cause of the hemorrhagic stroke is from drug-induced causes, like maybe a patient took warfarin and the patient developed hemorrhagic stroke, then you have to give vitamin K. So you have to give antidotes. So vitamin K, if it's apixaban, then andesonate alpha, rivaroxaban, andesonate alpha. If it's dabigatran, idarucizumab. So it depends. If it's snake bite from a viper, then you have to give anti-snake venom. So these are options to stop the bleeding. If the patient has maybe systemic illnesses like hemophilia, then it's bleeding, you can use the anti-hemophilic factor. So either factor 8 or factor 9, depending on the type of hemophilia, either A or B. So these are options that can be used in stopping the blood.
thank you.
Any other question?
Yeah, Dr. Ishak.
Yeah.
Mine has to do with the volume. Let's assume you want to prepare the hepatitis solution for a patient and you're using the normal saline and the 20% mannitol. So in this case, what volume are you preparing exactly? Is it a 500 or what the patient wants?
So it's easier preparing it in a 500 ml bag because the normal saline comes in 500. So it's easier preparing the 500 ml bag and drawing the volume that you need. So if you are using it for ICP reduction where you need 250 to 300 ml of the 30% hypertonic saline, you can prepare a 500 ml bag and give maybe your 250 in the morning, the remaining 250 in the afternoon. And so you can do that.
So, look, in this case, since we are doing a combination, how the meals asking in terms of the volume of the normal saline, the volume of the 20% mannitol to make up for the 500. How are you going about it?
So this is the alligation method.
Okay.
I don't know how to demonstrate alligation, but what eventually you get is 2.1 over 19.1 times 500 mils for the 20%. then 17.1 over 19.1 times 500 mils for the normal saline. So you end up with 445 mils of the normal saline and 55 mils of the 20%. That will give you a 500 mil volume.
Okay. No, thanks so much for your time.
Okay. Any other question? Okay. So the other thing is BP management. So aside your osmotic agents, BP management is very key in hemorrhagic stroke because the hematoma, the more the hematoma expands, the higher the neurologic deficit. So there's a direct correlation between hematoma expansion and the neurologic deficit. So the patient came with speech impairment, facial palsy, and all that. If the hematoma keeps expanding, then the symptoms will worsen. So it's important to control the hematoma size. And how you control the hematoma size is to reduce the BP. If you don't reduce the BP in hemorrhagic stroke, the patient will keep bleeding and the hematoma will keep expanding. And that translates to higher neurologic deficits. So it's the opposite for ischemic stroke. So we're talking about the fact that for ischemic stroke, when they come, you don't do anything to the BP unless the BP is greater than 220, 120. And that you give your IV labetalol. If it's less than that, you don't do anything about it because of the risk of causing ischemia, further ischemia. However, hemorrhagic stroke, the main aim is to reduce the BP. By reducing the BP, you are going to reduce the hematoma size. So there's a more drastic reduction when it comes to the BP reduction for hemorrhagic stroke. So that one, when they come in, is 220, 120. You want to reduce it by more than the 15%. However, hemorrhagic ischemic, you don't want to reduce it by more than 15%. So basically, that's the difference. You do a drastic reduction for the hemorrhagic stroke compared to the ischemic stroke. The neuroprotective agents, we've already talked about them. It's the same for hemorrhagic stroke, just that you can't use paracetam. You can only use somazina in here. And statins are not recommended in hemorrhagic stroke. Remember the pleiotropic effect. It has antithrombotic properties. These can worsen the bleed. However, if the patient has evidence of dyslipidemia, then you can put them on statins. So if there is evidence of dyslipidemia, you can put them on statins. There's actually a trial, the Flint et al., where they put the patient on statins, hemorrhagic stroke. They didn't see any significant increase in bleeding. As a matter of fact, it rather improved the outcomes and reduced hospitalization rates. So it was seen to be beneficial in that trial, the Flint et al. Trial. But generally, it's not used in hemorrhagic stroke unless there's evidence of dyslipidemia. For DVT prophylaxis, ischemic stroke straight away, when they come after 24 hours of your altiplase, you can start with your DVT prophylaxis with Clexane. However, if it's hemorrhagic stroke, you don't initiate Clexane within the first 24 hours, within the first 48 hours, because Clexane is going to worsen the bleed, even though you are trying to prevent DVT. These patients are immobile in bed. There's risk of DVT. When they develop DVT, you know DVT can lead to PE. Between PA and hemorrhagic stroke, they are likely to die faster from the PE compared to the hemorrhagic stroke. So you have to be very careful to prevent DVT. And in doing that, we are saying for hemorrhagic stroke, you can only start DVT prophylaxis with Clexane after 48 hours. Within the first 48 hours, you don't start. This is because it will worsen the bleed. But after 48 hours, it's said that the hematoma would have been stabilized. So any anticoagulant you are using after 48 hours in hemorrhagic stroke. Hello. Hello.
Hello, Doc. Please, you are here.
Yeah, I went up a little bit. What was I talking about? What was the last thing I said?
Doc, you were explaining the use of Clexane. You said after 48 hours, the hematoma is stabilized. That's where you went off.
Yeah, so for hemorrhagic stroke, you don't initiate DVT prophylaxis within the first 48 hours. So if you want to do DVT prophylaxis, then it should be after 48 hours. Even that, you have to be careful because there's still some risk of bleeding. So you do the low dose, the one 40 milligram daily. Even though there are other references that if the patient is more than 100 kg or BMI is more than 40, there's room to do 40 BD. But you wouldn't want to do that in someone with hemorrhagic stroke. So the low dose is what was actually tested in the trial. So they did 40 milligram daily and they realized that after 48 hours, it didn't increase the hematoma size. So for this reason, it's safe to use after 48 hours. The other option is the intermittent pneumatic compression, which is not readily available. However, if the patient should develop DVT and has hemorrhagic stroke, there's option to do IVC filters. IVC filter stands for inferior vena cava filter. So you place it in the inferior vena cava to filter any clot that can potentially get dislodged into the heart and find itself into the lungs. So what you are afraid of when you have DVT is P. So if the clot is in the leg, you put an IBC filter to prevent the migration of that clot to the lungs. So these are options, but it's also not readily available. So you may have to stabilize the hematoma, treat for some time, then think about doing a full therapeutic regimen for the DVT. Any questions? So if there are no questions, we'll end here.
Dr. Shak,
Yeah.
Dr. Shak, please, what would be your take on including polyphenol-rich cocoa in the management of as non-pharmacological treatment?
Yeah, so you can do non-pharmacological with all these diet therapy that have antioxidant properties. So the polyphenols in cocoa, they have antioxidant properties. So they may help, but there's no evidence, strong evidence to support routine use of cocoa, but they may help. So because they have some benefits in BP reduction and glycemic control, they may have some benefits translating into stroke, but there's no strong evidence to support the routine use.
Okay, thank you.
Hello, Dr. Shah.
Yeah.
I beg of you, when you are giving the figures for the ratio for the preparation, I think my line was not that clear, so I had the 90 as 19. Please, can you help me confirm that?
19.1.
Oh, okay, that is 2.1 over 19.1.
So basically what we are doing is, so picture, we want to prepare 3%, right?
Yes,
we have
please.
0.9 sodium chloride and we have 20%. The difference between 3 and 20 is 17. And the difference between 2.1, the difference between 0.9 and 3 is 2.1.
Sure.
So you add the difference. So between 20 and 3% is 17, and between 3% and 0.9 is 2.1. So 2.1 plus 17 is 19.1. So the 2.1 corresponds to the volume for the 20%. The 17 corresponds to the volume for the normal saline. So it's 17 over 19.1 times the volume that you want to prepare. So if you want to prepare 500 ml times 500 ml, and that will give you the volume for the normal saline. Then for the 20% is 2.1 over 19.1 times 500 mils, and that will give you the volume for the hypertonic saline.
Thank you very much. Thank you so much.
Sir, please, I have a general question.
Okay.
Sir, please, like in answering section D questions for clinicals, is there a difference between like medical problems, medical conditions? Like when you ask me to identify the medical conditions in a case study.
Yeah, so you list all the abnormalities. So the medical problems, if the patient has diabetes, past history of diabetes, hypertension, you list them. If the patient is presenting with chest pain radiating to the neck, to the back and all that, you are thinking of angina, you add it. If you check the electrolytes, sodium is low, hyponatremia is a medical problem. If there's high BP, so you don't have evidence that there's hypertension, but the BPs are high, it's a medical problem. If the sugars are low, it's a medical. So everything that is abnormal is a medical problem.
Yes, yes, please, sir.
So the medical condition is the condition itself.
Okay.
So So if there's diabetes, there's hypertension, there's stroke, these are medical conditions. A medical problem is everything that is abnormal.
Okay. Yes, please. Thank you very much.
Okay. Any more questions?
And sir, please, is it always that you have to list the goals of therapy before like writing the management?
So if they ask you management, usually is the pharmacological and non-pharmacological. They usually don't require goals of therapy. If they want goals of therapy, they'll ask you goals of therapy. But if you look at the marks allocated and you're seeing like 20 marks, and whatever you're writing is like 2-3 lines, it's better to add everything. So make it holistic. So goals of therapy, your non-pharmacological, your pharmacological.
Yes, please. Thank you very much.
Okay. Any more questions?
Hello. Hello, Dr.
Yeah.
Shah. Yeah, so please, this is a junior one. There's a new guidelines on the pharmacy business. I wanted to confirm if you should use that one instead.
Which new guideline?
It's about the pharmacy business. The first one we did for the laws was on the registration of the pharmacy and all that. I wanted to know if you use that
By
one.
that one, we've done it. Oh,
Yes, but I think there's a new one circulating and they've changed some things. We wanted to know if
we've changed some things.
Yes, please.
Okay, I have not seen the new one though. But it's basically what has changed now is it's no more the hard copy that you go to pharmacy council, you fill the form 1, form 2, form 3. No, now it's the PA1, PA2, PA3 is now online. So you do everything online. So I don't know whether the new one is about that. But if there is anything, it shouldn't change much. It's the same principle. So if you've read the old one, you can just scan through the new one and see maybe the changes. But other than that, it's the same thing. Any more questions?
Dr. Ishak, also there's a circulating PDF containing a new list of the drug classification. So please, we wanted to also confirm if we should also like glance through or like the first one we discussed is fine.
There's another new list. Hey.
Yes, please.
Yeah, I've not seen those things. So all those ones, I've not seen it.
Yes.
Because the one I sent to you was actually a new list of classifications. So I don't know if there's a newer version of that. But
yes, please.
That I know is a new list.
Yes, please. Thank you.
So all these things you can go through and see maybe if there's something new that has been added. If there's nothing new, then there's no need going back.
Yes, please, Dr. Ishak.
Please, the one who is talking about the new list, I'll be glad if you can share on this page so that we compare. Yeah, some of us have not seen. Thank you.
Okay. All right. So if there are no more questions, this will be my last meeting with you. I wish you all the best. Make us proud. Okay. Thank you.
Thank you, Dr. Ishak.
Okay. Bye-bye.
Bye.